really well received and had a lot of great questions. So if you are coming back for that, welcome back. And if it's your first time with Dr. Jones, welcome for the first time. But Dr. Jones is a naturopathic endocrinologist and a world-class expert in hormones, as well as many other natural medicine topics. She is also the medical director for the Dutch test, which if you're a patient here, you know that we use quite a bit for hormone analysis. And, we know that hormones are really involved with overall health. And we can talk a little bit about that also in relation. I'm going to do like a 1-minute sidetrack on COVID, since we're all kind of talking about COVID nowadays, with community updates. So here, I'm going to skip this slide because we have talked about this last week, but the virus is evolving. We know that there's research to test vaccines' effectiveness against viral variants, but we also know that in terms of root cause, the healthy immune system is equally as important as measures to curb virus spread. So generally, we want to reduce inflammation, improve detoxification, do a healthy lifestyle, treat metabolic syndrome, get the vitamin D levels up, and get the blood sugar levels down. Glycosylation of the ACE2 receptor does increase the propensity of the spike protein to the receptor, which basically means that if you get your blood sugar down, you're less likely to be infected, based on the physiology. But we also know that hormone health is tied to immune health. And I just wanted to share this one slide. Oops, no, I totally messed that up. Let me just, wait, yeah. So there's links between hormone and immune health, and I'm not going to really go through all this, but just to say thyroid hormone matters, cortisol matters, melatonin, testosterone, estrogen, progesterone have all been researched now. It's been about a year, I think, since the world has been affected by COVID, and there's a bunch of research that's been going on about, how even things like low estrogen levels are a risk factor. Progesterone, if it's too low, can be a risk factor, as well as testosterone. And optimizing these things can be associated with less severe COVID, increased lymphocyte number, decreased CRP, and things like that, decreased inflammation. Cortisol in the right amounts, as in terms of hydrocortisone, has been shown to be effective against other viral infections like other coronaviruses and things like that. So just to kind of get that in your minds about how the body's connected. It's not all about like one system, but the systems are all connected to each other. So when you improve one system or you improve multiple systems and you combine that with lifestyle nutrition, that's going to really give you the best outcome. Next week, we are going to conclude February with Mukit Airsali and I will do a quantitative EEG talk, talking about Evoke quantitative EEG for brain health, which is another special interest of ours here. But I just wanted to welcome Dr. Jones here. I'm going to stop the share, I think, and welcome Dr. Jones again. Thank you so much, Dr. Jones, for
Thank you so much for having me, Dr. Wong. I really appreciate it.
Yes.
And all of Capital Integrative. I love talking with all of Capital Integrative.
So the most important question is, did you guys get snow there in Portland?
We did get snow. Yes, we got snow on Friday, and it's the south of Portland. I live in Portland, Oregon, so south of Portland, they actually are still without power in a lot of places and without internet, and so it's not as bad as Texas, but at the same time, it is. Yes, I have snow out my window right now.
And you do have power, it sounds like, though.
I have power. Yeah, I have power. Great. Yeah, and Portlanders were a little more, we're not like the East Coasters or the Northerners for snow, but we're a little more prepared. Like, we have mountains around us, so we know we dress warm and we have a lot of waterproof.
Yeah, I have a friend in Texas, and unfortunately, they're not prepared.
Not at all. Their infrastructure can't handle it. We have better infrastructure.
Good. Well, we can start with the review a bit because some people are probably new from last time. So welcome again to everyone, and thank you for spending your lunch hour with us here. But what is the Dutch test, Dr. Jones? If you could just kind of get into that a bit.
Thankfully, it's an at-home test, which is really nice through all of COVID when people don't want to go to the lab and they can collect at the ease of their own home. Mm-hmm. So it's an acronym. It stands for Dried Urine Test for Comprehensive Hormones. So it's these pieces of filter paper, the main test, pieces of filter paper, and you urinate on them throughout the day, because we're looking to see in the morning, a couple hours later, around dinner, before bed, if you wake up in the middle of the night. And we'll use all that data off the urine to get your hormones such as estrogen, progesterone, testosterone, your cortisol throughout the day, your melatonin, some of these other, some B12 marker, a B6 marker. And so by having all of that at this nice at-home collection, we can really get a comprehensive overview of what's happening with your hormones, short of thyroid. We don't test thyroid, but we test a lot of other markers.
Yes, and thyroid we can get through the blood test. There are
Yeah.
some patterns on Dutch that may suggest a either hypothyroid condition. Is that right?
There are. And the cortisol, that's what we're looking for. So when we have a couple of cortisol dials, which people, if you've done cortisol testing before and it wasn't Dutch, that might be new to you. But we have what's called a metabolized cortisol, which is kind of like how much can you make and metabolize through your body. And then we have what's free and available. And depending which way those dials are turned, they look kind of like a speedometer. One of the ways looks like a hypothyroid pattern. So if I see that in a man or a woman, I'm going to say, ooh, looks like something's going on with your thyroid. Best to have that checked. Now, when I say thyroid, just like you do, it's more than just TSH, thyroid stimulating hormone, right? We're looking especially at the free hormones, free T4, free T3, what's going on with your antibodies. So it is much more than that screener test.
Right. That's just the tip of the iceberg, really, if anything. Well, I just wanted to ask a general question just so that people here listening can kind of get to know you a bit. How did you get into natural medicine and specifically endocrinology?
So I've known forever, since I was a little girl, that I wanted to be a doctor, and I thought I wanted to be an OBGYN or a pediatrician. So it was always centered around, honestly, hormones. I just didn't know that at the time. And then I went to undergrad with the intention of going to become an MD, right? To go to conventional, traditional medical school. And I was working in two hospitals. We had two hospitals in town. I was volunteering in both of them. And one of them I worked on the pediatric wing, and in the other one I worked in their community outreach program. And I loved the community outreach. I loved the education about diabetes and exercise and blood pressure and taking care of your health and not smoking. And in the pediatric wing, it was very sterile and it was very medication surgery based. And I thought, I don't think I'm cut out for being a hospitalist at the very least. Like it's needed, it's warranted, it's important. It's not what I wanted to do.
Right.
I ended up following a friend of mine, a girlfriend of mine who was moving to Portland. And I thought, I'm not going to medical school. I'll just follow her to Portland. And I needed a job. And I got the job at the naturopathic medical school in their admissions department. And I went, oh, this is where I'm supposed to be. So I worked for the school for 2 years.
Nice.
Went to school for 4 years. And then I did my residency in women's health and hormones. And now we have the naturopathic medical community doesn't have the amount of board certifications that like you have as an MD. But we're growing. So we have an oncology board, we have a pediatric board, and we now have an endocrinology board.
Oh, is that new, the endocrinology one?
It is, it's newer. And so I was one of the first to sit for the I sat in 2020. I sat for my endocrinology board exam and became a fellow of the naturopathic endocrinology
Congratulations.
Board. Thank you.
You're already an expert, but that even certifies even more.
Now I have more initials after my name. So yeah, it's what I love. So I joke. I'm like, if you've hurt your knee, don't come to me. If you want to know what to do about your newborn, I have no idea.
No, it is about prevention optimization. I agree. I mean, there's acute life-saving interventions that can be really helpful with Western medicine, but certainly with a more naturopathic integrative approach, that certainly is where functional approach. This is where this is what we do a lot here too. Great. Well, we're going to talk about COVID a bit here, since I know this is top of mind for a bunch of people. How is COVID affecting hormones in your experience at Dutch? Are you seeing any patterns on the Dutch testing, etc.?
It's too new to see patterns, but we are trying to anecdotally start to track. I should say observationally start to track when people write in, I had COVID, or this is post-COVID, or I just, dealt with COVID, and then what do their hormones look like? And I actually just did a consult, I want to say on Monday, of a woman whose cortisol was very low. Her progesterone was low. She was not ovulating, and she should be. Her estrogen was not right. And she had COVID in March, and she was still struggling. She was still struggling with fatigue and muscle pains and dizziness and just some of the shortness of breath, long haul COVID symptoms we've been reading about. So she did a Dutch test among a lot of other testing to figure out what's going on, like how is it affecting her downstream. And based on just the initial reading that I've done, I've seen I was just reading an article the other day about how post-COVID is affecting testosterone in men. It's affecting, just like you said earlier, our cortisol levels. It's because it's a virus and our immune system activates. which affects everything in our body. So for women, that can absolutely affect how we make our hormones, because the body will pivot, and like protection is key in safety. And so the body will pivot, and instead of saying like, oh, sure, ovulate this month, that's not it, make a baby if you want to. The body's like, no, we're not going to make these hormones in the right amount, because we're going to work over here on getting you better and dealing with this infection or dealing with the post-infection. And so it's too, to us, it's too early to draw conclusions.
So
but
maybe like more towards
aldosterone,
cortisol, and not as much towards DHEA and the sex hormones. Is that what you're thinking?
It definitely, unless yes and no. So it depends how soon after COVID it is. For example, if you are acutely fighting a virus or an infection, cortisol goes up. It's supposed to. It's anti-inflammatory. But after a while, cortisol will drop down. There's something called a negative feedback loop, where the body's like, we're done with this, enough. And it slows the production. And so people start to say, I am so tired. I am so worn out. I'm so burned out. I don't have the resiliency that I used to since having COVID. And having low cortisol is one of the contributing factors that we'll probably start seeing more commonly.
Great. I know we have a hard stop today around 12:45, so please type your questions in chat. I think I'm going to start getting to the questions, if that's okay.
Absolutely, please.
Great. So Carol, thank you for this question. Carol is asking about thoughts on timed released progesterone for someone on HRT to help sleep through the night. I'm assuming Carol might mean oral, maybe?
So that you can do, there are the time release progesterone to sleep through the night. It's definitely an option if your practitioner thinks that might help you sleep through the night. But also keep in mind, while progesterone is just one thing to help you sleep through the night, there are a lot of other things go into sleep. Melatonin is a big one. Melatonin should be up. Melatonin's like the moon. Cortisol goes up with the sun. So is your cortisol down? Is your melatonin up? How is your blood sugar? Like what's going? Did you have alcohol? Did you have a glass of wine before? That's going to affect your liver, which can wake you up. Do you wake up with hot flashes, night sweats? Is the person next to you snoring? Do you snore or have sleep apnea? Which, believe it or not, I was taught, and you probably know this, but I was talking to a sleep specialist, and he said, as women transition into menopause, perimenopause and menopause, their anatomy, their hormone structure changes what's going on here, and they'll start snoring or start to develop sleep apnea. And he said, I really recommend women who maybe their partners start to tell them like, hey, you're starting to snore.
We had the holistic dentist on in the myofascial PT. And that's exactly what you're saying. It's actually the facial bones and the soft tissue. It's actually dynamic over time. So the hormones can really help that or can, I guess, alter that. So that's very interesting.
So I love progesterone. Yes, but it's definitely not it's not the end all be all.
Yes. What else do you like? I'm going to use Carol's question also the opportunity to ask you, what do you like for sleeping in general? I know that's a very broad question depending on root cause, but just to kind of help people sleep.
Yeah. So first of all, a lot of it's, I guess, technique, right? It's lifestyle. So your circadian rhythm, you're up in the morning, down at night, is set by lightness and darkness. So making sure you're winding down at night, you're starting to dim the lights. You've got either blue light blocking glasses if you wear them. Be mindful of your screen time, your phone time, your computer time, your TV time. Be mindful of what you're looking at. I found a lot of people in 2020 were watching, all the Netflix murder mysteries and all the Netflix scary thrillers, because they were like, I'm at home. What else do I do? Right.
Yeah,
and I'm like,
no, I got it.
I'm like, well, now you can't sleep because you're scared or revved up.
Yeah, I like the Bono. I like the Bono glasses. I like the amber glasses there.
Right. I do that as we head into the evening for sure. And then, again, like I was, getting your sleep evaluated, getting your snoring evaluated, your people you're with, are kids in bed with you or animals in bed with you, waking you up. And I know some of these things people, they're like, well, it's not negotiable. We co-sleep, or it's not negotiable. My dog sleeps with me. I'm like, all right, we're going to have to do the best we can then, because that's potentially greatly affecting your sleep.
Yes.
So then I'm a big fan of calming things. So I'm a big fan of tea. So holy basil, which is called Tulsi. It's made as a tea. One of my favorites, chamomile, the sleepy time teas. Some of them have even valerian in it. Valerian's really calming. Magnesium glycinate. Glycine in the glycinate is a calming.
That's nice.
Amino acid. And so some people ask me, well, can I take melatonin? I'm like, so you can, but it's a Band-Aid. Giving melatonin doesn't make more melatonin. So make sure you're still addressing the sleep issues. What's got you up at night before just lying on
the other thing that people always ask too is like, if I'm taking melatonin, can I still be on my cell phone? But the thing is, the cell phone activates dopamine because it's that pleasure from the apps and different things. So with adrenaline. So that's great. Thank you. Yeah, and we have a question from email here, 44-year-old female that is asking, I don't have her name here, but it says, what is the best way to get a good urine sample for someone, I'm assuming that they're doing the Dutch test, who has an irregular period? So let's see, total number of days of the cycle are between 22 to 31. It kind of varies. And then they have unpredictable mid-cycle spotting.
So the first thing that we want to evaluate is, do you still ovulate? And at 44, even with an irregular cycle, you may totally still ovulate. And so buying the ovulation predictor kits, or they're called LH strips at a pharmacy or online or grocery store, and urinating on those, usually, like maybe if you have a 22-day cycle, sometimes like maybe start around day 8 and you'll do it every morning. And what that tells you is that you have LH in your system, and LH is a hormone, luteinizing hormone. And from start to finish of your LH, you're going to ovulate in about 24 to 36, 24 to 48 hours. So once you know that, once you're like, oh, good, yay, I make LH, I'm probably going to ovulate, then you would count forward 5 to 7 days and do the urine test. And that will give you, because we're looking to do it after ovulation, because we're hoping to find the peak of progesterone. So first, see if you ovulate. And some women are like, oh, I know I ovulate. I get warmer because progesterone's warming. Maybe you're wearing like a Fitbit or an iWatch, an Apple Watch, or an Oura Ring. And so you see your temperature go up a little bit, your mucus changes, you feel it. Like, great, ovulated, count forward 5 to 7 days and do the Dutch test. And so that way, even if within a regular cycle, or just a little variable, because maybe you're 44, then we can try to catch you at the right time.
Got it. I haven't asked you this before, but do you ever try to do the Dutch test? Do you ever recommend to people to do the Dutch test if they're ovulating on a time that's not luteal, like either at ovulation or even like day 3 or 4 or something like that?
I don't, only because progesterone at that time is really low, and most women want to know their progesterone. But what I will do is a cycle mapping. So the cycle mapping is where a woman collects pretty much every day of her cycle, and then we graph it out. So you'll see your estrogen and progesterone literally plotted out on a graph. So if a woman has mid-cycle spotting, or let's say she has migraines on day 14, or she's, moody here, and here, we can look on the graph and go, okay, here's what your hormones did that day and the days leading up to it. And so that can be a really nice, like, step back, look at the forest over the trees as opposed to looking at the tree.
When would you use the Dutch cycle mapping, which is that cycle long test, versus the Dutch complete test, or which would basically look at the adrenals and the sex hormones and the metabolites there?
Well, the great thing is you can combine them. So we can still do the all month long and still look at your adrenals and some of those other markers, which is really nice. So I love the cycle mapping, especially when a woman says, I get hormonal symptoms on these days with an S, or migraines is a classic example. I get ovulatory migraines and I get period migraines. I get severe depression on these days, and then it goes away, and then my depression comes back. I get hot flashes on these days, and these days. As women start to track, and sometimes,
which is likely a hormone imbalance.
Totally, usually, often. And so I'm like, let's do a cycle mapping. And same for fertility. My fertility women, I love doing cycle map, so I can see, best chances, like what's your progesterone and estrogen, what are they doing? And then what can we do to improve that for best fertility chances?
Okay, great. Thank you so much. Sherry is asking, we're going to go down the rabbit hole a bit here. Interested in your thoughts about the impact of the vaccine, or I guess the COVID vaccines as a whole, on hormones.
It's way too early to tell. I don't know. And I don't think I've yet had a single person at Dutch write in that they've had a vaccine and are doing the Dutch test. Because we aren't the ordering practitioners like you are. So unless you write on the form, had COVID, had the COVID vaccine, it's hard for us to correlate. So that I haven't seen that yet, but we are sure eyes peeled because we're real curious.
I mean, so certainly the people with long COVID symptoms, they might have either maybe over time some dysregulation of the HPA axis with cortisol, and then certainly downstream also sex hormones. So we'll I guess we'll get more information on that over time here.
Yeah.
Great. Well, Lise is asking feedback more than a question. Okay. My Dutch report is complicated to understand. There's a big, nice back pages of that, which is almost like a school education in and of itself, I would say. It's great. Learn so much from that. Yes, with the maps. It would be great if it were redesigned for patients to understand, or a second version for patients in addition to the healthcare provider version. That's interesting.
It is excellent feedback. And unfortunately, because we're a lab, we can't legally cater to patients. So we can't redesign it to say it so patients can basically like, we can't prescribe for patients, we can't diagnose for patients, we can't treat patients. I have a lot of men and women who write me on social media, and they'll go in the comments, in the DMs, like, here's my Dutch results, what can I do, what would you do, what do you recommend? And I unfortunately legally can't say anything. I'm not your doctor. So the test is designed for somebody to see a provider at least at this time, so that they can walk you through, especially if you need hormones, or if you need a prescription, or maybe you need other testing besides Dutch. Obviously I'm biased, but like, maybe like, you should have had a stool test as well, or maybe, gosh, thyroid, or, oh my goodness, we really need to go in depth on your cardiovascular markers.
Looking at the whole picture, partnering with the practitioner. Yeah, I think that's definitely the way to go.
I'm a big fan of being your own advocate. Yes, but to a point. Like, sometimes you need somebody to pull it all together for you.
Got it. Thank you.
Like Capital Integrative. You should see them.
That's right. Thank you, Dr. Jones. Carla is asking, can you speak to how you look at, or Dutch looks at, low neurotransmitters, especially norepinephrine and epinephrine?
Yeah, so I will be completely honest with everyone. The neurotransmitters on our test are metabolites of the neurotransmitter. They are not the actual neurotransmitter. So it's not like we're testing epinephrine, norepinephrine, and dopamine. We're testing how they come through the body.
Because it's urine.
Yeah. And so they are also at the whim of the two enzymes that break them down. One is called COMT and the other is called MAO. So COMT and MAO. So here's a classic example. They're really low on testing. And then somebody says, oh my gosh, I have low dopamine, low norepinephrine, low norepinephrine, but I'm anxious, I'm wired, I'm addicted to sugar, and I need my wine at night, and I like online shopping. So it sounds like in their body it's high. What can happen is they could have a very slow clearance of these neurotransmitters. So when they come through on urine, they're low because they're floating around the body so much and they can't get out. Another classic example is my best friend. My best friend is a very slow MAO. And so when she gets stressed out, she stays stressed out for a long while. When she does her neurotransmitter test, it's low, not because she doesn't make it, but because she doesn't break it down.
And so it's floating around in the bloodstream. Yeah?
Exactly. Okay. And so it could be deceiving because people go, oh my gosh, I have low dopamine, I have low norepinephrine, I need to boost them. Like, well, hold on, we have to correlate your symptoms. And if you know your SNPs, if you've done COMT and MAO testing, but not everybody has, totally cool, symptoms with the results. And then let's try to figure out what's going on. And sometimes high levels doesn't mean you're high. Sometimes high levels means you have a fast MAO or a fast COMT.
Just a tangent on that. Do you have a certain nutrigenetic testing that you like to do? I know Bob Miller has some testing and other places.
His is a good one. So the common popular ones, his is a good one.
23andMe, I don't know if you like that.
23andMe, the problem with 23andMe is that they've pared down their plate so much. If you have an original, like an OG from years ago, it's really good. Currently, it's Seeking Health is a good one. That's Ben Lynch's. He's a really good one. And then Life Code DX. They're out of London. I don't know that one.
Okay.
They're out of London, but they're really good and totally shipped to the US, no problem. And then DNA Life, they're out of South Africa, also shipped to the US, no problem.
Good. Okay.
I've had mine done with all of them. Okay. Honestly, because perks, everyone's like, well, why would you get your DNA? I'm like, perks of the job.
Perks of the job. Yeah. Nice.
So they send it, they're awesome. Like, it's here, spit in this tube.
Yeah. Yeah.
So, and
And
so
they're
I
all
like
pretty
the
accurate. They're
reports.
all pretty accurate. They're precise that way.
Yep.
Got it.
Yep.
We have a great question here. I know this is probably on the top of mind for a lot of people. Women in her early 40s. Jenna, thank you for this question, Jenna. Do you recommend BHRT, bioidentical hormone replacement therapy, for a woman who's gone through menopause in their early 40s?
So honestly, it's very bio-individual. So the first question is, does BHRT, well, let me back up. What is BHRT? Just quickly, most everyone means estrogen, but remember, bioidentical hormones can mean thyroid, it's bioidentical, DHEA, testosterone, progesterone, estradiol or estriol or estrone. So those are your main sort of bioidentical hormones. And so, but most women are talking about estrogen when they're talking about this because their estrogen freaks them out. So, and then it's bio individual. Am I afraid of estrogen? I'm not afraid of estrogen, but I don't give it out like Oprah gives out cars. I'm definitely like, let's test you. Let's see what you're going to do. What would happen if I gave you estrogen? Let me talk about your back history. Let's look at some lab work. What are your symptoms? And then I go forward from there. There's actually, I have it right here.
What kind of cars is Oprah giving out?
She's got that classic episode where you get a car, right?
Yeah, so, very nice, very nice.
This is my favorite book. See if I can get it in the light. It's called Estrogen Matters.
Okay.
It's written by doctors Blooming and Tavris, but you just Estrogen Matters. And they went through all the literature about estrogen to give it the pros and cons. They talked through the WHI trial, which is the big trial that halted all estrogen, HRT. And everyone freaked out. It was like, oh my gosh, estrogen causes breast cancer in everyone. But what's really interesting that I want women at least to understand here today is that you probably know somebody who had breast cancer and never even went on the birth control pill. But they've never been on estrogen in their whole life and they still developed estrogen.
Right.
And so it which goes back to bioindividuality and, their genetics, their upbringing, their current history, their lifestyle, their environmental factors. And so I'm not afraid of estrogen, but I do not give it out to everybody.
Yeah. And a lot of it seems to be insulin regulation and toxins, at least from, not all of it, but certainly a lot of it.
A lot of it. Yeah.
We're definitely going to recommend, antioxidant status. We're definitely going to check with anyone on bioidentical hormone replacement therapy, BHRT, a Dutch test, because we're going to want to check how they're detoxing estrogen, or is it going down to simplify, a anti-inflammatory pathway or more pro-inflammatory pathway? What is their CMT status based on the methylation and things like that? So this is going to be really helpful. So this is really important for everyone out there that's on bioidentical hormone replacement therapy. If you're going to see a practitioner and they're not checking your levels of metabolites, you don't really know where that estrogen's going. And you want to be, I think, we generally want to be safer about it. And this is the way to do that. So,
And the other thing, if you're listening and you're on estrogen and you're not on progesterone to counterbalance it, especially if you still have a uterus, you haven't had a hysterectomy, then that's a big no-no. You have
now if you don't have a uterus, though, is that what do you think about that there? Yeah,
I still think you need progesterone because of all of progesterone's other benefits. I find that women really, progesterone's calming, it's relaxing, it's soothing, it's helpful for a lot of other things. Immune, right? We talked about immune in the beginning. And so I understand why they say, oh, you've had a hysterectomy, you don't need progesterone. You don't need to protect against uterine hyperplasia because you don't have a uterus, but you're missing out all the other benefits.
And it should have an anti-inflammatory effect anyway. So it, in theory, would be protective against breast cancer even without a uterus.
It might. It could. Okay. Yeah, it depends. Depends on the woman still, right?
Right.
Yeah.
Okay. Amanda asked, thank you. Amanda asked, for someone who is low carb or even keto part of the time, could you explain the best times during your cycle? This is a great question, to incorporate carbs. So this carb cycling question, both in terms of how estrogen affects insulin and carb intake during your cycle, and also why carbs are necessary for ovulation and for healthy progesterone levels.
So with carbs, I would say most of my keto or intermittent fasting or fasting experts that I talk with suggest that you should at the very least incorporate them in the 7 to 10 days leading up to your period. That you want the carbohydrates for the neurotransmitter. This is the serotonin, the dopamine support as you lead up to your period. And so really with carbohydrates, if you are too low carb, what can affect is actually the hormone called leptin. So leptin is a hormone that is made by your fat tissue. It's a signaling hormone, and it goes up to your brain and signals if you have, basically, like, if you've eaten enough or haven't you, like, do you need to burn energy? Do you need to eat more energy? And so what can happen is if leptin is not able to talk to the brain to say this, let's say you have very low levels, like maybe in somebody with very low body fat as an example, then the body says, oh, there's no leptin, therefore she doesn't have enough, her fat stores are too low. It's not safe to ovulate, therefore I'm not going to. And so for some women who don't ovulate, and they are maybe borderline low to low body fat percentage, we see this a lot. Athletes, right? This is a big one. I can see it and have seen it in my keto or my very low carb people, where it's too much of a shift for the body. And so as a protective measure, it doesn't, you stop
and
ovulating.
just speaking more generally, and the research it doesn't seem like there's as much research supporting intermittent fasting or low carb diet for premenopausal women, unless they have metabolic syndrome, maybe, or something.
Right, it's a tool. So is Cynthia Thurlow. She has an amazing TEDx talk on intermittent fasting. I just adore her. So Cynthia Thurlow. So she says, she's like, it's just a tool. It's just a tool. And exactly that. If you have cardiometabolic disease and you're using intermittent fasting to your advantage, and even neuroprotective, I've seen people say it helps them focus again, which I think is
maybe the ketones,
even not blood sugar related. And then it's just a tool. But if you are 100% relying on it for,
right,
it's like, this is what you do every day, no matter what, it could really affect your hormones.
Got it.
Negatively. You got to be careful.
Great. A lot of questions here. So Anina is here. Hey, Anina. Anina is asking, can you explain why prometrium, which is basically bioidentical progesterone, helps with lower alpha pregnenolone, and is 200 milligrams in normal dose in the second half of the cycle?
So prometrium only comes in 2 doses, 100 or 200, and it is bioidentical progesterone, but just be aware it does have peanut oil in it. So if you have a peanut allergy, then be careful with prometrium. So what happens when you swallow progesterone, whether it's prometrium, whether you got it compounded, whether it's in drops, anything you swallow, when it goes through your liver, it blows apart into metabolites. It's called first pass. And when you blow it apart in all these metabolites, some of them are alpha and some of them are beta. The alpha metabolites continue on down the alpha pathway and they become something called allo, A-L-L-O. Allo crosses the blood-brain barrier and binds to GABA A receptors. GABA is your biggest calming neurotransmitter. So it's a very calming effect from the brain down when you take prometrium. Now you still have all that beta. It's genetic, which way you prefer, alpha or beta. But the beta doesn't have the calming effect like the alpha does. Now, I will say, for those of you who have PMDD, so premenstrual dysphoric disorder, you have to be very careful with progesterone sometimes, because research is showing that allo, that alpha metabolite, when it goes up and down, some women with PMDD, their GABA receptor can't, think of like pistons in a car, like the pistons can't change fast enough to deal with the allo that like comes and then goes away and then comes and then goes away and comes and goes away. And so it results in a dysfunctional GABA receptor and PMDD. So now you will read in the research, and for PMDD treatment, they're actually using what we call alpha blockers to help, leading up to their period, to try to reduce the PMDD symptoms. It's very fascinating.
Interesting, yeah.
But for the non-PMDD women, that's how it works. That when it goes through your liver and blows apart, some of those metabolites are alpha. They continue on to form allo.
I wonder if
compounding
and dividing it into divided doses might make a more steady state. I don't know if that would.
Steady state's the key word. Yeah, it's the up and down that messes with the receptor. Steady state's the key word. Yeah.
They need an IV then. IV.
Just walk around all day.
Yeah.
No, that'd be wonderful.
That'd be funny. Okay, great. All right. So then, so Lisa's saying she is doing the full cycle test right now, and she's excited to see what she learned in terms of the irregular cycles, which have been happening lifelong for her. Great. Thank you. Amber's asking, Okay, this is a great question. Have been taking BHRT, bioidentical progesterone, I think maybe only progesterone, for 10 years. Is it safe to continue?
As far as I know,
Yeah.
yeah.
Oh,
Yeah,
great.
progesterone's what I'll be so there's cell studies, they're not human studies, there's some cell studies. So that when you go down the alpha pathway, they form something called a 5-alpha pregnane. And it's that when you look in research, progesterone can go two ways. It can deactivate one way, or it can go to the alpha, which we talked about, the pregnane. In cell studies, having a high amount of 5-alpha pregnanes could increase cell proliferation and what's in something called detachment. And so I do have some oncology colleagues who don't like oral progesterone because they don't like the risk of the 5-alpha pregnanes. But when you push that into human literature and the studies out there, I don't know that I'm seeing it, but I'm also not an oncology expert.
Yeah. Is there a way to test
to
for
argue.
5-alpha pregnane or?
So we do on Dutch, we test
It
the
is.
5-alpha pregnane diol. Yeah.
Oh, that is part of it.
But we
Okay, got
don't
it.
test the other marker, which is so instead of the 5, it's a 4. It's just a chemistry thing. So it's a 4. So we don't test the 4 marker. And if you have plenty of 4 marker, that's considered more protective.
Got
so
it.
you could
Okay.
have high levels of 5-alpha pregnane. But you're fine because the other marker, the 4 marker,
is fine. Got it.
is fine, and counterbalances it. So it's definitely, but we don't bioidentical progesterone in breast cancer. I don't see like we read about estrogen.
I haven't seen that link the way that with estrogen. What about, I think Judith is asking, what about GABA? I guess that means like pharma GABA or some sort of straight.
Yeah, so GABA, so there's two thoughts about GABA. One is that GABA is a big molecule and should not cross into the brain. So if you take GABA and you feel better, calmer, relaxed, sleep, then you may have what we call leaky brain, like leaky gut. So you have a blood-brain barrier, maybe your blood-brain barrier has some holes in it, or things are sliding through your immune system that shouldn't. However, I have found a paper that says that when you take GABA and it hits your stomach, your enteric nervous system, so you're in the gut, communicates via the vagus nerve, which is your big, rest and digest parasympathetic dominant nerve, to make more GABA. So it's more of a wake up call. So
indirect.
You take GABA,
Got it.
and the vagus nerve is like, oh, all right, hold on, let me tell the brain to make GABA.
So either way, it would help. Essentially.
So either way, it would help. Yeah, it could. Yeah, some people take GABA and have nothing.
Right. And it may have to do with SNPs and the GABA, something like that. Metabolism. Okay, great. Pam is 71. She says that testing shows that she has a low progesterone, so started taking 25 mg, move up to 50 mg. Also, just to know, just as we said, disclaimer, this is not like medical treatment here. We're all talking about hormone health here, but did move up to 50 mg a couple weeks later, and she's taking that now. She's having sleep issues, is taking Zolpidem, which is a prescription for sleep. Does she need to increase the progesterone amount?
You have to talk to your practitioner, unfortunately. Yeah, we can't answer that on a live.
Yeah, I think that would be good. Test blood levels, do a Dutch test, just kind of see where you are and then see clinically. And a lot of times it's empiric, but yeah, I think talk to a practitioner about that. Michelle says after menopause, she was on HRT, but then stopped for financial reasons. Felt good when she was on it and wanted to start back again, but her doc says that she can't. I know there's some thought about, do the receptors go to sleep after you stop it and, things like that. Is there a gradual way, she says, is there a gradual way to rev back up to HRT?
Yeah, so there are actually some research, or there's this, people, they'll say like once you are 10 years past menopause, you shouldn't be on it at all. And then there's another camp that says actually being on, especially estrogen HRT, as long as you don't have cardiometabolic issues, that you can go on estrogen 10 years post-menopause. But I'm a big fan of low and slow. So if you used to be on it and felt great, and you bring this up to your practitioner of like, I'm good for it again, let's test me. I think I'd like it again. I'm having all these symptoms. Let's just start low and slow. And I think that's completely fair.
And it makes sense if the estrogen receptors aren't as much. If they went off of HRT, then low and slow makes a lot of sense because then you start waking up those receptors again.
Versus going back to your original dose and just, blasting the body, with it. Yeah.
Right. Because it is all about how we metabolize the hormones as well. And that's where doing low and slow makes sense.
Yeah.
Great. So Anina also asks, why do you not take anything that would suppress prostaglandins when on day 11 through 28?
Yeah. So prostaglandins are, so they're chemical messengers in the body, and they help you ovulate. They help you break apart the follicle so the egg can come out. And they are what gets released when implantation happens. So the burrowing happens in the uterus, and prostaglandins get released, and they go up to the brain and they announce you're pregnant. So if you take prostaglandin inhibitors, such as over-the-counter NSAIDs, or maybe high-dose fish oil, or a whole lot of curcumin, turmeric, it's possible that you could affect, in a sensitive woman, you could affect her ovulation and her implantation. Mm-hmm. This is not across the board. Absolutely, definitely depends on us, on your sensitivity. But I tell women, especially my fertility women, I don't care how bad your headache is. If you are trying to get pregnant, don't take ibuprofen or anything around ovulation to implantation. So just be aware. And I absolutely have had feedback from women who heard me say this before, learned it somewhere, and said, I was taking so much fish oil, or I was like, maybe they have joint pain, so they were taking lots of turmeric, and they were like, I was having so many progesterone issues, and so I stopped, and lo and behold, my progesterone issues went away.
Got it. Okay. Mm-hmm. So this is a woman that has a question about not having a period, but what I think this is what the question is, but she's getting headache, nausea, and sinus issues every month at the time of her cycle, like a regular kind of thing. And she's asking why that would be.
So if if you're not having your period with your period, like let's pretend you had a partial hysterectomy, but you still have your ovaries. So you don't bleed, but your ovaries still work. Or for those women listening who do get a period, there is something called a period flu. And it's the shift in hormones as you're getting closer to your cycle and you're not pregnant, the drop in hormones, because your hormones are so intricately tied to your immune system that it can trigger flu-like symptoms, which is not fair or fun, especially in our COVID era, because every woman is like, this is it got me. And then they start their period and they feel better.
Okay.
So if you look up Google period flu and you will read about it.
Interesting.
It's not a real flu. It's not like, but they just call it because the symptoms are similar.
You shouldn't have a fever. You shouldn't have coughing, lung symptoms.
But they'll be like, I feel worn down. I feel achy. I feel headachy. Like I feel so blah. And then like you're going to get sick, that like, am I getting sick? It's like that feeling. And then the period comes and they're like, oh, okay, it was my hormones.
Thank you. Great question here from Jennifer, 67-year-old female taking Bioidentical YAM progesterone compounded, I think that means ST. I don't know if that means, I'm assuming that this is a compounded, like a capsule, 100 milligrams. Working great for sleep onset and maintenance, but noticed immediately that she gained 5 pounds. I'm assuming that's from the progesterone, like just that there's an effect of progesterone also.
It might. Yeah. So it does. Progesterone can affect water. Your water balance. We often think that progesterone helps us release water, but I was actually reading about progesterone yesterday, and depending on the person, progesterone at those receptors, they're called mineral corticoid receptors. Progesterone can be pro or con depending on the person. So I have
maybe
had
talk to
women
your practitioner about decreasing that dose a little bit.
Yeah, exactly. Exactly.
When to do the Dutch test for postmenopausal women?
Anytime on a typical day. Since you're not bleeding, you don't have a cycle, you can do it any day. Do pick a normal day. Please don't pick like a relaxing weekend, or if you are allowed to travel, a vacation day.
Yeah. A sort of a normal stress day or something. Facebook question here. So about migraines, what are the thoughts about possible relationship between hormones and migraines, especially around your cycle?
Yeah, so there's actually good research to show that predominantly it's around estrogen, although I have seen it with both progesterone and testosterone. But it's the shift in estrogen that shifts, believe it or not, serotonin, that affects what's called our trigeminal nerve. In our trigeminal nerve is here. Well, I have my little thing on. It's here, and it causes in our head, and it can cause migraines. And so that shifting estrogen, shifting serotonin upsets, irritates the trigeminal nerve. So yes.
Do people know yet? Do we know, like, is it serotonin or estrogen or both in terms of the migraines?
So because estrogen has such a big role in the creation of serotonin, that it is both. We know that that they go hand in hand.
Got it. Okay, great.
Yeah.
Thank you.
Yeah. And also with migraines, I have lots of women that once they get their estrogen detox better, I have women that say, I've been working on my hormone balance, my liver health, my gut health. I've added magnesium in. Like their migraines definitely start to lessen. So I say, as we talk estrogen, Dr. Wong and I say estrogen, but migraines are definitely multi-system that probably needs addressed.
Absolutely. Gut for sure, micronutrients, and certainly hormones, among other systems. So we're about to conclude here, but Dr. Jones, I'd love to have you on again as usual. So glad it's good to see you as usual. I hope that the power remains on there as well, and and we look forward to having you back again soon. Thank you so much for coming on, and we will talk to you again soon.
Wonderful. Thank you so much. Thank you so much, everyone. It was a pleasure.